Hello everyone, Andy Marshall here, your host on The Mixer, back with my buddy Juan Carlos Lopez.
Hello Andy, good to be here. Very excited about a new episode of The Mixer. So who is our guest today?
So our guest today is Dan Kaufman. Dan's a professor in the Department of Medicine, Division of Cellular and Regenerative Medicine, and he's director of the Cell Therapy Program at UCSD. Dan's been a long-time proponent and innovator in the area of natural killer cell therapies for blood cancers.
Indeed, and he recently organized a Keystone symposium with Hans-Peter Kim and Sonia Schrepper on emerging cellular therapies. So we're hoping to hear what happened at the meeting, and I'm sure we'll hear a lot about advances in NK cells as well as in related areas.
Great. We should also disclose Dan is a co-founder of Shoreline Bio and advises another company, Therabest, which are both in the area of cell therapy. So let's get started with the conversation.
Let's go. Dan, we're very happy to welcome you. You're fresh from organizing this meeting, Emerging Cellular Therapies at Keystone. And looking at the program, we found different things that we thought were very interesting in this field, and hopefully we can touch upon some of them. One of them is this move beyond CAR Ts, which have really dominated the field for a long time. It seems that now people are gaining a lot of new insights into B cells, NK cells, an area of your own interest. Hearing a little bit about that would be helpful. Another thing that we found that would be very useful to discuss would be the expansion beyond cancer and beyond the blood. The advances that people are making in fields like autoimmunity in particular, retinal diseases, even neuroscience. That's a second point. And then the third point, which is even newer, and I think that we're going to hear a lot of surprises in that space, is in vivo cell engineering as opposed to ex vivo. So to me, those are three areas that are very exciting, and it would be great to hear what was discussed at the meeting, your own thoughts about them. So why don't we start with the work on different cell types, considering that you've done a lot of work in that area and made some very important contributions into NK cells in particular.
Yeah, I guess, again, in terms of background, one of the things we wanted to do at this meeting was highlight things beyond CAR T cells, right? So we had some of that. There is a lot of other interesting work. And as you said, my area of interest is on NK cell therapies and allogeneic cell therapies in general, right? And, these can come, so especially for the NK cell work, can come from different sources. All my work has been from human pluripotent stem cells. We started 20 plus years ago using human embryonic stem cells and then have largely moved to induced pluripotent stem cells, or iPS. And both can work quite well for making NK cells or natural killer cells. And, the advantage for me of using iPS cells is it forms a really excellent platform for gene engineering or modifications, right? So we can have a standardized cell population that we've expressed CARs, so we have iPS-derived CAR NK cells. We've improved expression of proteins like CD16, which is an FC receptor. We've done work, which I talked about, to knock out things like the TGF-beta receptor, which can be inhibitory to NK cell function. There's a gene called CISH, which is sort of a negative regulator of IL-15 signaling, and we're doing other work to make drug-resistant NK cells. And you can do this all in one population and derive all your cells from that. So there are other groups, so Katie Rizvani also presented, and she's done excellent work with cord blood-derived NK cells. So they make batches of cells that I think now they're the point where they can treat dozens or maybe 100 or more patients with a standardized cell product from what they've seen. But I think whether it's iPS or NK or cord blood, and this is one of the things I've highlighted with sort of a challenge for the NK cell field, is that all the trials are relatively limited in size, right? So a lot of either academic investigator-initiated trials or companies now like Fate Therapeutics that has translated iPS NK cells into clinical trials, but hasn't really gotten beyond phase 1. Part of that has to do with the scaling of these cell sources and how they might be best utilized. But, I think the trials that have gone on, whether it's iPS or cord blood or peripheral blood, so there are many trials, which is how this really started, using NK cells isolated from allogeneic donors. Again, this was really pioneered by my colleague Jeff Miller when I was at University of Minnesota, who used haploidentical donors for treatment of relapsed AML, and that's been very effective. We've done work for 20 years showing about 30 to 50% of patients who get these allogeneic NK cells for AML can get into remission, some of them lasting a year or more. But how do we scale that beyond the individual trial, which I think has been sort of the challenge in the field. The other part about allogeneic cells compared to the autologous CAR T cells, because they are foreign cells, is the persistence of the cells, right, and how long they maintain. Typically, these are given with lymphodepleting chemotherapy, which suppresses the patient's immune system for some period of time. The cells survive for typically a few weeks, but then they largely disappear. You can potentially redose, which I think a number of these trials have been doing, and try and increase the scale that way. But it's a trade-off from the autologous cell source where patients' own cells can survive for months or years, right? And may be important for maintaining that longer-term remission. We just don't really know at this stage. So it's been an interesting field to see develop, and I think will continue to develop.
So, Dan, there's essentially, you've mentioned kind of three sources, the cord blood, peripheral blood, or, using iPSC derived cells. I seem to remember some people were also working on these immortalized cells. Is that still kind of ongoing, or?
I don't think very much. So there is this cell line called NK92, which is essentially, as you say, an immortalized NK cell line. Very easy to genetically modify. You can do all this stuff. The limit there is they have to irradiate the cells before they give them to the patient, which further decreases their persistence and activity. I don't think there's been a lot of enthusiasm for NK92 cells. I think it was sort of an early trial to move this, and I haven't seen as much of that now as maybe 5 years ago, right? And it seems to be moving more towards these other cell sources.
And the early work, I always seem to remember the cancer was AML, that's Jeff Miller, yeah?
Yeah, that's really where I think continues to show the most activity. And even without a CAR, so NK cells have different activating ligands, inhibitory ligands. Tumor cells the NK cells express the receptors, the tumor cells express the ligands. AML cells are known to sort of upregulate some of these NK cell ligands. So again, even without a CAR, they can kill, especially those types of cells, quite well. Solid tumor, other tumors then require engineering with a CAR or so on. Incidentally, one of the short talks at the meeting, Mary Daher from MD Anderson, who again works with Katie Rizvani there, actually did very nice work characterizing how patients with AML, their NK cells become dysfunctional, possibly, I think, through TGF-beta production and other mechanisms. So again, which is why, presumably, if you give these third-party NK cells that are not dysfunctional, they can take on that activity as well. So I think that's also sort of additional insight of why the allogeneic NK cells might work well for AML. But my real bias, I think AML is sort of the CD19 equivalent for NK cells, and I really wish there are all these companies and stuff developing their products, and they're doing CD19 and other stuff. And there are some doing AML, but I think that's where we can really gain ground for NK cell-based therapy.
This last point you made, I find very interesting, that companies aren't getting into this space, even though there's data already from phase 1 trials showing that this works.
To some extent they are, but I wish it was more, I guess.
Yeah. So I wonder, what is the roadblock, right? Is it that it's hard to manufacture these cells? Is it that we still need technological improvements to get higher yields of these cells? Is it that we still don't understand the biology enough to move them forward? Or is it something more related to clinical development in the sense that maybe you're going to have to show superiority of this versus standard of care, and that just seems quite hard to achieve. So which of these different things you think is the main roadblock to move this approach, NK cells, to more successful clinical trials?
So, I mean, there's a couple parts to this. There's one sort of more successful NK trials in general, and then also why isn't there more being done for AML? And I think it's maybe a recognition of the clinical need and maybe the company business models and so on, because it is maybe a relatively rare disease, though I think that the need is there. Incidentally, also CAR T cells, autologous CAR T cells, I think are not very good, sorry to bias myself, for AML, because all the antigens are shared with normal hematopoietic cells. So groups are doing things like knocking out CD33 and hematopoietic stem cells and treating patients and potentially transplanting HSCs after. There's no way to scale that in a great number of cells. So again, NK cells really fit that well. In general, I think the challenge is, as you sort of suggested, a lot of this is in the manufacturing and scale of the cells. I'll say maybe especially for iPS-derived cells, I don't know as much about the clinical scale manufacturing of cord blood or peripheral blood, but each, I think, has its challenges. One thing we have learned from these trials is we have to get the cell dose up substantially. So Fate, for better or worse, were the first ones on the block to do this. And obviously they started with unedited NK cells and then, one edit and now multiple edits. Whereas a company now like Century Therapeutics is doing iPS NK cells. Their first product, I think, had 6 or 8 gene edit. Fate has also started with a relatively low dose, 100 million cells times 1. And then you have to wait a long time between patients because it's a sort of first-in-human trial. Now we're looking at trials getting up to 10 to the 9th cells and multiple doses of 10 to the 9th cells. So that's getting to be a pretty good number of cells to manufacture and store and bank and all that stuff. So, I think it can be done, and there are groups that are doing this, but it is a challenge. And so I think the manufacturing right now is the biggest issue, and I'm trying to remember sort of the other items you brought up.
Yeah, if we needed a better technology to increase yield, so that has to do with manufacturing. The other one was how much of the biology do we understand so that we're comfortable moving forward. There's always more biology to learn, but it doesn't sound like that's the holdup.
Yeah, I mean, obviously we're pretty good at characterizing the cell populations, and there may be subtle differences between these cell sources. I mean, we've done comparison of our iPS NK cells to peripheral blood and cord blood. There's going to be some differences, but to me, they seem to be more alike than different. I've heard people suggest that the iPS NK cells aren't fully mature, but that's not the case in our hands. They mature over time as you expand them in culture, and we have ways to do that. So I don't think it's biology that's the limit. So, it's the manufacturing. And then it's the immune activity, as I mentioned before, right? So again, like Century and others are working on making more what can be called stealth cells, right, or less immune reactive. And again, Sonia Trepford talked about this some at the meeting, more in the setting of non-immune cells, but the principle holds, right? So can you knock out class 1, class 2, add HLA-E or other CD47 to prevent NK cell killing, and so on? Because the longer you can make the cells survive, presumably the better their activity. I think that's also a challenge people are trying to focus on.
It would be quite nice to move on to the next issue that we introduced at the beginning, which is the different therapeutic areas in which people are beginning to try the cells. But before we do that, I wonder if there's anything that you saw at the meeting that is particularly exciting about B cells.
Yeah, Paul Cannon talked about B-cell engineering to make sort of anti-HIV antibodies. But there's also the talk by this company called B-Bio that I thought was quite clever, that they're just engineering the B cells to be protein factories, right? So they're not worried about making antibodies, but they're very good about making proteins, right? So they can make things like factor 9 for hemophilia, and I think they plan to be in trials, later this year. I thought that was interesting and not necessarily for just immunology purposes, right? Again, it's sort of a way of delivering gene therapy or whatever protein that you want to have for repair or replacement of what's missing. So, yeah, I thought that was an interesting new area.
So this is a kind of new modality, where we're able to produce, for example, I think B-Bio, and there was another example of a company that I came across, Immusoft, where they're producing actually an enzyme in vitro. Yeah? It's a really exciting new modality, really. Did they talk at all about the advantages of this compared with traditional enzyme replacement therapies where you're injecting the recombinant enzyme itself?
Not specifically for those areas. I think the advantage is that these would be engrafting cells, right? And the advantage for a lot of these things is you don't need real high levels of these proteins or enzymes, right? If you get like 5 to 10% of normal levels, people do pretty well. The other area, and maybe we can come back to at the end because it's a little bit different, again, comparing to gene replacement, was Don Cohen's talk at the end for immunodeficiencies, right, and HSC gene engineering. And there he did talk about, because some of these are done for storage disorders or so on, where they do give enzymes as sort of standard of care, and now they're trying to do the HSC gene engineering, which I think is fantastic. So there they did talk a little bit more of, he talked about one versus the other, but not as much necessarily for these other conditions.
Before we leave NK cells, though, I have a couple of questions. First is, one of the advantages of NK cells was the fact that compared with CAR-Ts, you're not really suffering from the same kind of issues with cytokine storm and immune rejection because they're these allogeneic cells to an extent, when you're using haploidentical. So given the fact that all the time this is going on, the CAR-T cell field is finding ways of dealing with cytokine storm issues. Do you see that kind of advantage of NK cells kind of falling behind, or do you still think that, they're the kind of gentle giants, aren't they, compared with T cells?
Well, we didn't get into sort of the advantage why we want to do allogeneic cell therapy in general, whether it's NK or T cells. Part of it is the cost, right, which you didn't. So the autologous products that are made on a patient-specific basis that cost about $500,000 just for the manufacturing is significant. And when these ever do expand into solid tumors or things where the market might be 10x, that could be an even bigger issue compared to, the CD19. So cost, availability, right? So the autologous therapies take about 3 weeks to manufacture. Not every patient has that amount of time before their disease progresses. So again, if you can have a quote-unquote off-the-shelf cell therapy product that's there where the patient needs it, those are the type of things that we want to move to. I do think the CAR T cell field is moving towards shorter manufacturing periods. The toxicity, it is an issue that's probably also an issue why autologous CAR T cells have to be done at a tertiary specialty medical center, because patients do get the cytokine release syndrome, or neurotoxicity is the other major issue. NK cells don't seem to cause that, and even though they're allogeneic cells, they don't cause graft versus host disease. And maybe it's getting somewhat better for the CAR T cells, and without taking this the wrong way, it as part of the effectiveness of the cells and the proliferation of the cells, a little bit of these immune reactivity and stimulation is not necessarily a real bad thing. And maybe I wouldn't mind seeing a little bit more in the NK cells to show that they're getting activated a little bit more up until a point. We are definitely getting better at managing these type of toxicities. It's an important consideration. I don't think that's the major differential between autologous and allogeneic therapies. I think it's more the cost and the availability and the standardization of the product. Because for an autologous therapy, everybody's getting something different. And if it works or doesn't work, is it because of difference in the tumor? Is it difference in the cell product? And so on. But if you have a standardized allogeneic product, you can better understand what is important for efficacy and not, because everybody's getting the same thing. always use the example, I want this like my blood pressure medicine. When I get it, it's standardized. Everybody gets the same thing. I go to the pharmacy and pick it up, and it's ready to go. It's not made on a one-off basis. I think that's eventually where we want to get for these cell therapies. So that the other analogy is like antibody therapies, right? So again, when I was in training and rituximab came out 25 years ago, this is the first CD20 monoclonal antibody for cancer treatment, was effective. There were some side effects. People would get some immune reactivity against this. And as a protein product, and people are like, how are we going to make enough of this? How is this going to be used? And now there's dozens of monoclonal antibodies that you can get for cancer therapy and non-cancer therapy. And you can get them basically anywhere in the world. And this is very standardized. So, we're not obviously there yet for the cell therapy, but 20 years from now or so on, maybe that's hopefully where we can get.
So one last question, because we need to move on. Where do you see the killer app for NK cells compared with T cell?
AML.
AML.
I think that's really should be the focus. I think CAR T cells, auto don't work that well, or they have, again, complications. We know NK cells will work. You might be able to make them even better. There is still a tremendous clinical need for better treatments for relapsed AML. When we first started doing this, I hear things like, there's 8 new drugs that have just been approved for AML. They all target individual sort of gene mutations. None of those are curative. Whereas, I think in the right scenario for NK cells, they can be. We've done some work to make these even more effective. Again, if people are out there listening and interested in this, go after AML. I think that's the best application for this.
The other area we were trying to get some insight into was the new therapeutic areas where cell therapy is going to claim wins.
Yeah.
Right? And people have been talking about autoimmunity for a while, the retina. There were some talks at the meeting on neuroscience applications. What's happening in that area? Where do you see the low-hanging fruit or the...
No, these are all very interesting. Getting back to the CAR T cells, there was a speaker from a company who's, I actually don't think they are in clinical trials yet for the CD19 CAR T cells, but they talked primarily about work that's been done in Germany that first did some of these trials or continue to do and has published some of this on CD19 CAR T cells for primarily lupus and maybe moving into autoimmune disease.
Was that the work by Fabian Muller?
I believe so.
Right, yeah. University Hospital Erlangen, is that right?
Yes, I believe so. Really fantastic results, right? For lupus, it's like 10 out of 10 or 12 out of 12 patients,
right,
all in CRs, going out 2 years or more, no disease activity, like gone. It's very early stages, but very exciting. Everybody's jumping on the bandwagon now for this. So, every CAR T cell, allo, everybody's saying, we're going to be an autoimmune company now. Great. It's a lot of enthusiasm over a dozen patients. And it is a little bit different in how we think about the pathogenesis or pathophysiology of autoimmune disease, which has been typically thought of largely T cell mediated, but these are knocking out B cells, which for lupus probably makes sense because you get a lot of autoantibodies produced and so on. Whether it's the same thing for other autoimmune disease, I don't know if it'll work the same. But I think very interesting, and I think that's in the to be seen. The other thing that was brought up, and I think is important, because we started treating a few patients for multiple sclerosis with considered a standard autologous hematopoietic cell transplant. This is not a CAR T. But what I saw from those patients and what was mentioned here is treating these patients, collecting the cells, manufacturing the cells, and so on, from non-cancer patients seems to be much easier than from cancer patients. And these are patients who have not seen chemotherapy before. Their bone marrow is not as beat up from previous therapies. So they collect a lot of cells. Their immune cells are very healthy. The patients do very well with this. And so while we would like to move towards allogeneic cell products for these things, and there's obviously going to be the logistics and the cost for the autoimmune disease. The toxicity and the patient health may be easier to manage, at least at this point. And the long-term persistence of those cells may be important. We don't know. So again, the autologous T cells will persist for months or years. Allogeneic cells, probably not so much. Whether you can just give one big knockout punch and reset the immune system which is kind of what people also claim that these do. And there's a lot of hand waving around that because nobody's entirely clear what that means, but it does seem to help. So early stages, everybody's, again, jumping on the bandwagon there.
Obviously, cancer, there's this kind of risk-benefit ratio,
Yeah.
And the toxicity of the treatment that you will be prepared to endure to fight the cancer. Autoimmune disease is a slightly different risk-benefit ratio. So I'm just wondering if you could talk to two aspects. So obviously, there's been a lot of chatter quite recently about these lymphomas that have been discovered in a tiny fraction of patients who have received these CAR T. Was it 6 approved CAR T therapies they found? Roughly 14 cases among 27,000 doses given. Vanishingly small. And yet, if you're fighting cancer compared with fighting an autoimmune disease, that may seem to be part of an issue. And then the other thing I wanted to ask about, obviously, lymphodepletion is an important part of the pre-treatment. So do you think that we're going to get around lymphodepletion for autoimmune indications?
Well, we also don't know how much that's part of the therapy, right? That's good treatment for autoimmune disease. And that's actually one of the questions is how much of the cells helping versus just chemotherapy.
Right.
When we do this for MS, it's an autologous hematopoietic cell transplant. It's essentially just giving a big slug of cyclophosphamide, which is very immunosuppressive. The cells are incidental. They're just a way to rescue from the toxicity. So it is really the immunosuppression that benefits that. And again, MS is now accepted by the American and European BMT societies as autologous transplants being an effective therapy. Some of these autoimmune diseases are just as lethal as cancer. So the mortality of somebody with severe lupus, those curves can look very similar to some malignancies and some types of lymphoma and so on. So I think that the clinical need is there. The risk-benefit in terms of toxicity and secondary malignancies is very much the same. I agree. I mean, the amount of consternation that's come up about these T-cell lymphomas from the CAR T-cells, we don't know if that's from the tumor. We don't know if it's from the cells. Again, it gets into why having a standardized allogeneic product could be better if it's just as effective, right? Because you wouldn't presumably have some of these integration effects or stuff that might cause that. So that's going to be a concern, but there's still a lot of other treatments for the autoimmune disease. It's not like everybody's going to get it. And so it's for these very refractory cases where you want to do it. And so I think the risk-benefit becomes more neutral when these patients have essentially an equivalently lethal disease. And then there's just the toxicity of the treatment itself, right? As you mentioned, the CRS and the neurotoxicity. And maybe you accept a little bit more of that in a cancer therapy than an autoimmune disease. But again, the patients may be healthier. They may be able to better tolerate these things. So hopefully there's not some untoward event that sort of sets back this whole area.
Sometimes it's not only what the patient is willing to accept in terms of risk, right? It's what the regulators think would be a good risk. And that's where some of these therapies end up meeting an unsurmountable obstacle, the regulatory concerns, more than what the patient is willing to accept. Yeah, we should move on to so you were about to tell us about the other areas like retina neuro.
So yeah, the other area I wanted to highlight is a neurologic disease. Lauren Studer from Memorial Sloan Kettering, who's really pioneered a human ES cell-derived dopaminergic neurons and now working with a company called Blue Rock that's treated a dozen patients with these dopaminergic neurons for Parkinson's disease. I don't know how much efficacy data they've presented, but certainly safe and exciting to see that in trials and seemingly going well. The other was a talk from a company called Neurona, which have done at least one of their patients here at UC San Diego for epilepsy. So they have a way from ES or some other early stem cell source of making inhibitory neurons, I believe. So they're actually using this to treat patients with refractory epilepsy. They presented 6 or 7 patients. Again, these are early phase results, but these are patients who have seizures and even in these early trials have gone away to a large part. early stages, but really interesting and exciting to see these things getting in the clinic. Those are all interesting areas and great to see the field progress. A lot of the comments you hear about sort of the stem cell field is like, well, it's a lot of hype, but what are you really doing? And now all these different diseases are getting into the clinic. I don't think we had a speaker from Vertex, but we wanted somebody to talk about iPS-derived pancreatic islet cells, which are in trials. Sonia Schrepfer talked about that to some extent. Other groups working on liver. I think there was even a short talk on biliary cells. So those are maybe a little further behind, but islet cells are certainly in clinical trials. Cardiac cells continue to get worked on and so on. More and more getting into the clinic, I think, is great.
It's interesting to hear about the experience with the Parkinson's patients and the epilepsy patients. As you may know, there's a literature that goes back 40 years ago when people were doing these kind of transplants from embryonic cells.
Yeah, right.
And it was similar to this. The initial experiments came up positive and people were very excited. But when people did the more rigorous trials, it was like 1/3 of the patients would get better, 1/3 would show no effect, and 1/3 would get worse. So hopefully in these cases, we're find a better success rate. But it's a very difficult area in which to get results. And then there's the concern about generating tumors. And again, 40 years ago, when people were talking about these kind of transplants, there were a lot of concerns, some of which actually were very legitimate. So it will be very good news if this new generation of therapeutics are more successful.
Yeah. I followed this field for Parkinson's. Kurt Fried and such did these trials with fetal cells, right? I mean, but now the advantage is, again, we have a standardized cell source, right? Yeah. So if these are ES or iPS derived in those early trials, do people do better or worse? Because everybody was getting something different and very hard to standardize. Yeah. So now having the standard cell source makes it easier to understand who would benefit and who might not. So that's going to be an advantage going forward for any of these treatments. They seem to be having efficacy very early, even though they don't think these cells necessarily integrate or are really active for maybe a month or two. Patients seem to get better, whether it's placebo or something else, soon after they get the treatment or the immunosuppression or something else. So a lot unknown.
Yeah. 34 years ago, when people were doing those transplants, they found the similar thing. And people were wondering, so what is the mechanism whereby these transplants work? And they didn't know if it was a paracrine effect.
Yeah.
I don't think that people felt that those transplants really integrated in a meaningful way, restoring the previous network. I don't think that was the mechanism people were thinking about.
One of the key things about this meeting was the diversity of cell therapies that are out there now and how much of this is getting into the clinic. And that was the comment I think I heard from a lot of people there is I didn't know all this was going on. Everybody's kind of focused on their own area. So it was really good to kind of get this.
We've talked about autologous and allogeneic. It seems like we are moving into a new era. Is this one of the themes that you would take away from the meeting, Dan? That off-the-shelf cell therapies, which really is very much an important development if we're going to turn these into commercial therapies where you can distribute these effectively, manufacture them effectively. That leads to this question of, do you have a feeling that we're entering a new era in which off-the-shelf cell therapy is becoming a reality?
So I guess, again, it's whether you're talking about cancer therapy or non-cancer, right? I mean, I think it's clearly moving ahead in both areas. We talked about, again, the advantage for the allogeneic CAR NK cells compared to the autologous. And these other diseases, again, are by and large allogeneic cells. There are companies, and again, there's one here in San Diego, Aspen, that's actually doing autologous dopaminergic neurons for Parkinson's. More challenges there, but maybe less issues with immune reactivity. The last thing I think we talked about we want to touch on in the last few minutes is the in vivo therapy, right? I think that's really the next evolution of whether it's off the shelf or standardized or easier to deliver therapies, right?
So what do you see as the technological developments that are going to allow in vivo compared with what we've really seen so far, which is ex vivo modified cell therapy?
This is an area where my group has gotten into a little bit just because of the scale-up challenges with the allogeneic products. What if we could engineer patients' own cells to be the CAR T cells or the NK cells to kill tumor cells? Or it's also being done for gene correction for things like sickle cell disease or so on, right? So instead of taking the cells out or making the cells in the lab, engineering them, giving them back, give some sort of vector to repair or engineer patients' own cells. So the issues there are specificity, right, and safety and efficacy. How do you target just the cells that you want and not others? And then how do you do this safely? So there's a few different technologies that people are using, either viral vectors. I mean, this has obviously classically been done sort of with lentiviral or AAV vectors. But now moving beyond that, a big area of interest are LNPs, lipid nanoparticles. So this is what billions of people have now been treated with for COVID vaccines. That's a very large number. So these can be scaled up quite effectively. Our first speaker, I'll just to highlight from the meeting, keynote was Drew Weissman, who just won the Nobel Prize for development of this mRNA technology with LNPs that's been used for the COVID vaccine. So he's very much getting into other areas of LNP delivery. There are different ways you can use this, and I'm learning about as well. You can change lipid formulations to target different types of cells to some degree if they have a positive charge or negative charge. You can also conjugate them to antibodies, right, which is what we're doing, so you can target different immune cells or different cells of interest. The other area that my group has gotten interested in is so-called virus-like particles. So instead of having sort of infectious lenti or AAV, we can use a stripped-down version of this, as essentially a membrane delivery vehicle for mRNA to target specific cells. And again, those can be engineered in different ways with scFVs or DARPins to target different immune cells. Another way I thought was interesting to change or improve the specificity of this effect. So there's a company called Orna, which is for circularized RNA, which is another way to improve the persistence. And they've done this all with supposedly a charged LNP that can target T cells, NK cells, and macrophages by changing sort of the composition of the RNA with different iris sequences or different regulatory sequences. You can change how this is expressed or not in different immune cells. You might hit a lot of cells, but if you only get the RNA expressed in your cell type of interest, that's another way of adding specificity. We're interested in doing this for essentially engineering CAR cell therapies more effectively. Others, again, like my colleague Hans-Peter Kim or others, are trying to do HSC gene engineering for gene repair for sickle or thalassemia or immunodeficiencies potentially could be used. So early stage, but I think a lot of interest moving into this area.
We have one final question for you, Dan.
Before we get to the last thing, last speaker who I really wanted is Don Cohen. He shows 30 plus years of work for HSC gene engineering. He's been doing this, for treatment of immunodeficiencies. These are essentially bubble boy disease, right? Which they can now cure through this engineered hematopoietic stem cells. They've treated, and his group at UCLA, and they collaborate with groups in Europe, treated 50 or so patients with this and maybe more worldwide with fantastic results, 90+% long-term success. They've tried to commercialize this. So there's a company that sort of licensed this technology, and then they found they couldn't make enough money because there's just not enough patients. So they actually got the technology back into the academic setting, and they're trying to figure out how to move forward. So it's unfortunate when these business interests supersede the patient's interests. It's been a great success and hopefully an area to continue to highlight and move forward from. So it was very fitting to have him conclude the meeting as well.
Yeah, I visited his lab about a year ago. So we talked a little bit about this experience that you're sharing with us, that he had licensed therapeutics, but then there's no commercial model that might be successful, and then they have to go back to square one. It's quite unfortunate. And I completely agree that that's something that we need to address because the science is quite mature in that space.
Yeah, there needs to be some commercial solution for these things.
The last question, Dan, as you have seen, the podcast is called The Mixer. And that's because we always try to combine our interest in science with our interest in cocktails. So our last question to you is, what is your go-to drink?
I'll say I'm more beer than wine. If I'm having something mixed, if I'm making it because it's easy, is probably gin and tonics is easy. Manhattan would be the other sort of.
Manhattan, very nice.
I've tried to learn how to make good Manhattans, but it's challenging.
Well, practice makes perfect, right? And
there you go.
And
right.
Manhattan is very, very easy. The area code of Manhattan, as you know, is 212. So it's 2 ounces of whiskey, 1 ounce of sweet vermouth, and then 2 dashes of Angostura bitters. It's a very straightforward drink. I encourage you to practice, Dan, and hopefully next time you join us in the mixer, we can share a Manhattan with you.
Oh, keep that in mind. Yes.
Very good. Well, it's been a great conversation. Okay. Thank you very much, Dan.
Thanks a lot, Dan.
Yeah. Okay. Good. Thanks. Hope this turns out well.
All right. Cheers, Dan.
Conversation. Thank you.
Great. So clearly a lot of excitement in adoptive immune therapy, whether it's T cells or NK cells, and this move out of cancer to autoimmune indications. I was particularly interested in his comments about the quality of cells you can harvest from autoimmune patients rather than cancer patients. It's also going to be interesting to see whether these regenerative stem cell therapies pan out. They've been a long time coming. It's been many decades and still many questions of unsettled science, I think, how the cells implant, integration into existing tissue structures, issues such as immune stealth that Dan touched upon a little, and persistence, I think, are still quite up in the air. Then, of course, we've had the recent news that Vertex, which is the most advanced clinical trial of these ES cell-derived pancreatic beta cells, was stalled. So a lot of excitement, JC, yeah?
Yeah, I'm glad we had this episode. I think it's an area of great interest. I'm particularly interested in the regenerative medicine aspect of this because, as we talked during the episode, it's an area where we've been getting results for decades, and yet progress has been somewhat limited. I was very struck by Dan's comment that one advantage that we have now is that we can characterize the cells much better than we could in the past. And I think he's right. The fact that a lot of these new transplants and new experiments involve iPSC derived cells is actually a promising advantage. So I look forward to the results because the proof is in the pudding. Also, this thing about moving away from cancer towards other indications, I think it's very interesting. And if I were a betting man, I would bet for autoimmunity as the area where we're going to see exciting results in the near future.
What about Dan's choice of cocktail?
Yeah, Manhattan, very elegant drink. I love a good Manhattan. I didn't mention during the episode that the official whiskey for a Manhattan is rye whiskey. You can use bourbon or other varieties, but the official one is rye. And the other thing that I failed to mention is the final ingredient in the cocktail, which is a maraschino cherry. So that is what adds an element of elegance and some sweetness to the cocktail that is quite welcome. So hopefully we can share a Manhattan one of these days, Andy.
Absolutely. Look forward to it, JC. We'll put all of the ingredients down below in the description. Thanks, everybody, for listening. Thanks, Dan, for participating. And see you next time. Cheers.
Cheers.